So the CRISPR is a technology for editing genes that is very powerful, and that we use every day in our laboratory research, and it's being introduced now in ways that might be used in patients. And I think the way that it might first be introduced for patients with multiple myeloma is in the CAR T-cell therapy, that we might be able to engineer T-cells that would work in every patient, and not just the patient that they were derived from, if we can edit the genome of those cells. And that would be a big advance, because we would have off-the-shelf cells that could be used in everybody. That would bring the cost down and make it more effective. And that's not going on in myeloma right now that I'm aware of, but things like that are going on in other diseases. And so it's very exciting technology. The oldest person should answer that.
Yeah, thank you.
You don't remember, right?
Yeah. Yeah, it's like mad cow disease. You can only get it once. Yeah, I don't think there's any data on that, but the whole concept of chemo brain and kind of the recovery after the stem cell transplant, I think there's some reality to it, and so and yet no hard data. Nobody's really looking at neurological functioning after chemotherapy, but it wouldn't surprise me if it did affect people, and so I think that's the best answer yet. But we don't really have any good alternative currently, so I think that's the point.
More importantly, should anybody obsess about that?
Oh no, I think it's negligible. So if it does do something, it would be so minimal that you'd never be able to design the study to really find out. So like most people after a stem cell transplant, 6 months after, if you see them, they're as good as they were, if not better than when they presented with the disease. And what really impacts people's mental function is having active disease. And sometimes that can make you feel really, really bad.
Well, first and foremost, obviously you're doing great, and we just, love to see that. There are different ways in which different people react to the different treatments, and that's obviously sometimes the cards we are dealt with. I think as you go down and you're looking at someone who has had myeloma for 10 years, we have patients that within the 10 years, and then there's a 15 years. Sometimes that is without treatment. Sometimes there's treatments that are peppered along the way that you can keep that under control. And I think it's just an example of how still we have to learn. So there is an effort to learn about cases like yours, where people will call them sometimes the super responders, people who can be out 20 and 30 years. And even when they have disease, they can still, be, for the most part, back to their normal lives. So maybe that's another plug-in for the health tree. That might be a way which we kind of start collecting the data for people who actually are going to be doing that well. I thought the image that Greg didn't want you guys to leave without this room is us trying to balance ourselves in these chairs, but
that's not my problem.
I think it's great that you're that far out. I kind of think it's very kind of telling to your long-term outcome. I kind of like to see people 10 years out and beyond, but I never stop following them up. You always have to pay attention, because complacency can lead to problems. So it's great. Don't become complacent, but be pleased.
Every 6
yeah,
months.
Good man.
Those are excellent questions, and there's no answer. But so I can tell you that we all probably practice it just a little bit differently. But certainly if you've got a measurable spike in your serum, or if you've got 10% plasma cells in your bone marrow, we don't need to do the minimal residual disease testing. So we do it when we can't detect the disease any other way. And so we often, at least I often do it shortly after the stem cell transplant, when we've given the sort of the most intense therapy, and see what sort of level of response we've achieved. And what I tend to do is if there's measurable disease with an M spike, I might use a triplet. Whereas if there's only disease that I can measure with MRD, I might just use lenalidomide. And if there's no disease, I'll still use lenalidomide. And then I would repeat it when I'm thinking about stopping the lenalidomide. And that usually often depends on the patient's side effects. If they're having problems tolerating it, their white count's low, they can't stay on it, okay, I'll say, let's see if there's anything there that we're treating. And if there isn't, then I'm more comfortable stopping.
So I totally agree with that. It's a kind of good way of using the technology. You need to have it in the clinic, and more and more people are becoming MRD negative. And so when you're following people long term, you may live a long way away from the doctors. Then you can have a scan, an MRD test. If those are both negative, that's a very good sign of being stable for a prolonged period, probably until your next monitoring. And so you can say to people, things look good, enjoy the next 6 months, chances of you relapsing very low, and then you can just go on over time like that, monitoring the disease. You pick up early relapse where you may want to do something, but I think it's very assuring for me and for the patients I treat. So it's a great question, and it's a complex answer. So things happen statistically randomly, and so sometimes they come together randomly. So it could just be pure chance, and that's one explanation. The other explanation is there are some families that have more myeloma than you would expect. It's often with other cancers as well, except when you look at the genetics, it's not like the type of genetics you're used to. It's polygenic, and so up to 60 different genes can contribute to the risk, and they're not inherited in a kind of standard way. So that's a complicated way of saying you don't need to worry about your children or your siblings because it's probably random and there's no testing that you could find. And even if it was a twofold increase in risk, it wouldn't amount to anything significant for any individual. And it works in a population, but not really for an individual. And yeah.
Strangely enough, my sister's husband had multiple myeloma. Dr. Fonseca was his doctor. And his mother also had multiple myeloma, as did his aunt. He was also Ashkenazi Jewish, and they had a BRCA1 mutation in his sister had breast cancer. But he didn't have that mutation, and we looked in him, and there's no obvious mutation. But these, as Dr. Morgan was saying, these things happen. But we do have a clinical study that is available now looking for familial genetics. Dr. Stewart just said something around about that. Just opened last week, I think. So that'd be something that you might be able to enroll in.
Okay. The issue is you need to get hold of genetic material from multiple levels, the parents, the offspring, the offspring's offspring, because myeloma happens in the age of 60 to 70. Often the parents aren't available. And so I think, Jenny's health tree approach, as you get out into the population, you should be able to find families, collect the material, and it's the perfect substrate for a study. But for you, I don't want you to worry about your family because the chances of it being relevant is very, very low, infinitesimally low.
Boy, I'm so sorry to hear. Of course, that's one of the most difficult side effects we're dealing with right now. I think as we have learned that we can have many more years ahead of with myeloma, the neuropathy is pressing more and more as something that is to be avoided. Now, the way we're using these medications, there's some strategies to prevent that from happening, but it's far from perfect, not 100%. Over time, things tend to get better, although there's always some residual effect. And what I would tell someone is, let me help you with your symptoms. There's nothing we can do to heal the nerves. We can fix sometimes symptoms like pain or discomfort. We would encourage a person to engage in strength, exercises, keep walking, put an extra effort. Easier for us to say, I realize, but that's what we would do. And in the future, I think this is going to be one of the most pressing questions. Right now, most of our patients we have treated with Velcade as frontline treatment. But when you have someone who has so many years ahead, this is really knocking on the door of the question, should we, for instance, be considering the carfilzomib, which does not cause peripheral neuropathy. It has other symptoms as well, too, and other complications potential. But for now, I would say just give it some time. It's just something, obviously, no one likes to see that, and we do see some improvement over time.
Yes, I'd also like to add that sometimes being unable to stand might be from muscle weakness. And the steroids, the dose of dexamethasone, can contribute to that. And so we reduce the dose of dexamethasone or maybe even stop it completely, depending on how you're doing.
So I physiotherapy, build him up, see how he is in 3 months. There's a really good chance that there'll be some improvement. So you should be optimistic about the future.
Sure. So, as a team at Mayo, we evaluate all of our guidelines every 6 months. We have the MSMART. I don't know if you've seen those, msmart.org, where we put our consensus recommendations. For transplant, we consider acceptable that there has to be a mortality rate of less than 1%. Of course, we would want it to be 0, but there is a risk always of that mortality, and we consider that for myeloma, it has to be less than 1%. So based on that hasn't given a lot of weight on the negative side, right, to remove transplant from our recommendations. I actually believe in transplant as a key driver of the long-term control of the disease, particularly transplant plus maintenance. I think that's becoming an important factor. Now, there's a number of reasons why someone may not want to or cannot go through a transplant, other health issues, sometimes personal and professional preference. And I always say, the patient's at the driver's seat. So you're piloting the plane and I'm the weatherman. And I'll give you my expert advice, but I will ultimately respect your choice and your health decisions. And that's kind of how I approach that.
So the mortality rate associated with, choosing a good patient and 200 mg per meter squared of Melphalan is probably less than 0.01%. It's often if you choose to do it in the wrong person. And so there's a lot of expertise around the centers in the US, in the academic centers, about choosing people for transplant. And so you don't want your doctor to get too carried away, start choosing frail 73-year-olds where you don't really give them any benefit, and you're better taking the alternate approach of using novel agents.
So the answer is no? It hasn't been reevaluated? Or it gets reevaluated every 6 months?
It's constantly reevaluated.
But it hasn't changed.
It hasn't changed. And if anything, there might be less use of transplants because there's so many better alternatives, or there's so many good alternatives.
Okay.
So it's important to know. So this is a very modern country with excellent healthcare. Only 20% of the people eligible for a stem cell transplant in the country as a whole receive stem cell transplantation. In California, they did a population-based study to look at what was the most important feature of good outcome, and that was having received a transplant. So there's kind of various lines of evidence now that point to stem cell transplantation being a major tool that we have that can improve people's outcomes.
Sure. So I'll let Dr. Bergsagel explain the SPORE, but I'll explain high risk. So high risk, the way we understand it is, what are the characteristics of those myeloma cells that make them more likely to be resistant to chemotherapy and more likely to relapse? And we define that primarily through the genetic testing. The standard of what we do in the clinic right now is any one of those three markers. They're kind of like cardinal sins, if you may. If you have any one of those three markers, we consider it high risk, which is deletion of chromosome 17, the translocation 414, and the translocation 1416. Now, that's kind of the very simple, in a nugget, explanation for high risk. Now, we are doing other testing, such as mutation analysis and the gene expression profiling for patients, which give you a different perspective on how you can define high risk. And all it means is that the person has a myeloma that more easily will adapt to treatment, so we have to be more vigilant and more intense in how we treat it.
The issue about high risk is that what is high risk, which is why I kind of appreciate the question. So, so some markers of high risk, so the 414, 40 to 50% of patients may be alive 4 to 5 years after they've presented. So if you wanted to change the treatment for that group and say make it more toxic to improve outcomes, that would be a very bad thing for 50% of the patients who don't have high risk. So it's about how do we pick up high-risk patients and how are we defining, or how specific are we that they have a very bad outcome? And so that's what we all talk about all of the time is, you know, do you use cytogenetics, mutation testing, gene expression profiling? And it's all about being very specific so that you could say to a patient, you really have high-risk disease, we should treat you differently. And that's the real aim of what we're trying to achieve.
Both of these guys left out the basic mechanism, which is the international staging system, which uses blood values, and it's a very crude measure of risk. But it looks at albumin, beta-2 microglobulin, LDH, and depending on the combination of those, they tell us a lot about the patient, in fact, about not just the tumor cell, but also what the patient. So that's also used to define risk. And then sometimes it's what happens to a patient. If the disease comes back within a year of transplant, those patients tend to do very poorly. And so sometimes it's something else altogether that says this patient is high risk. And now I'll answer the question about SPORE. So I'm the principal investigator of the SPORE, and I'm trying to think what SPORE actually stands for. But it's Specialized Program of Research Excellence. Yeah, that's what I was guessing. We never actually use that. So, but what it is it's a grant from the federal government that funds translational research. And translational research is the kind of research that will impact patients' lives within about 5 years. So it's not necessarily the basic science research that might be very esoteric. This is really directed towards making a difference in patients' lives. And there's one at the Dana-Farber Cancer Institute, and right now the Mayo Clinic has the other one from the federal government. And it supports a lot of infrastructure here for the research, the things that are really critical for doing translational research, like a biorepository and a clinical trials database, and things that it's hard to get money for those things in other ways. And the program we have here is looking at exciting ways. There's one of the projects looks at using viral therapy. And you may have heard previously about a patient from the Mayo Clinic treated with a measles virus who had a complete remission. She's actually a patient, she's doing fine, and she's a patient advocate for the SPORE now. She had a complete response to the measles virus. And we're looking at another virus right now that causes hand, foot, and mouth disease in cows. But we've tried to change it so we can use it in people. Okay, hoof and mouth. And We've got a program, a project that's looking at the heterogeneity that we were all talking about. I'm leading a project there that looks at the impact of genetics on the progression of the disease. And actually, my wife has got a project which looks at ways of modulating the immune system so that we can fight the disease. And so, but it's really a very clinically oriented research program that we're very proud to have and hope to continue.
I'm going to use an analogy to explain a little bit the high risk that I was just thinking as you were speaking, because high risk is something that is changing all the time. So let's imagine this is a classroom, okay? And there's like those kids in the back corner, I'm not pointing at you, but that 25% of kids are the ones who are getting the D's and the F's, okay? So that's what we would call traditionally high risk with our curriculum. But it turns out we started learning about them, and we know those kids, turns out they can't read the blackboard. So that's why they're getting D's and F's. So an example like that would be the 414. The 414 was high risk, but now we know, for instance, if those patients are given a class of drugs, the proteasome inhibitors, so the Velcade, the Ninlaro, carfilzomib, they tend to do better. So we actually are able to bring them to the front. So that's kind of one of the things with the high risk. The other side, this side of the room used to do very well in years past, and those are the 1114. The 1114 used to do very, very well. But with the new drugs, they were kind of falling behind. So they go from the A's and the B's to the C's and the D's. Now we have a new drug for them, for instance, the venetoclax, that it's helping us, and we'll probably talk a little bit more about that. So my point was going to be things change depending on the context, and things have changed depending on the treatments we use. So how we think about the long-term treatment of patients becomes very important. For those patients who were on this side of the room, the 414s, or the patients who have deletion 17, we think if you do a transplant, we better put into the mix after transplant a drug like Ninlaro, for instance. And that's how we're trying to approach this, more than saying, oh, it's high risk, things won't be good. It's what can we do for that group that is falling right now into the high risk category.
That's a very complex question. Okay, and it's sort of based on IFISH or cytogenetics, and there's one particularly poor risk marker which is called loss of chromosome 17p, and it varies in its percentage from 4% to over 80%. What we know with that variable is that you need a higher threshold, 50, 60%, for it to have serious prognostic importance. If it's 10%, it may or may not be relevant to risk status. And so what we should do is move away from that technology and use testing for the gene that we know is the relevant gene, which is P53. If you've lost 2 copies of P53 with a genetic test, it's not a good outlook. But most of the time, people haven't lost 2 copies, and so they have a perfectly good outcome. And so I spend quite a lot of time seeing people asking that question, trying to reassure them where they've been told they have terrible outcome because they've got 5%. And, you know, it's important.
Yeah, so that's in fact what Dr. Morgan was just talking about. And we're concerned about, on chromosome 17, there's the short arm, which we call the P arm. So we call that deletion of 17p. But we're all talking about the same thing. And it turns out that the culprit there is one single gene called P53. And if you've knocked out both copies of that gene, then we're quite concerned about you. But if you haven't, then we're not. And so we don't, I don't think the three of us really like to talk about loss of 17. We really want to know what's the status of that gene P53. We do that by doing a bone marrow and sequencing the tumor if there's any tumor there. If we find it, then we tend to be we alter our management. We really want to try and achieve a complete response in those patients and do everything we can to keep the disease from coming back. Pass it on.
You know, that gene is a very, very interesting gene. That gene, P53, they call it the guardian of the genome. So think of it like your editor. It's always making sure the genome is fine and there's no typos, there's no grammatical mistakes. And as long as that gene is active, our health, seems to be there. Out of interest, they just found a story about elephants. Elephants have many copies of this gene, naturally. And it turns out that elephants don't get cancer. And the reason for that is that they have this like proofreading process, like this editor that's constantly looking at our genome. And that's what many, many cancers have abnormalities with this P53. So once you lose that P53, that there's opportunities for mutations and deletions and all these changes. So that's what that gene does. So like the CRISPR thing, it's not far-fetched, and this is like into the future, but that humans in the future might be bred, whatever that means. Humans in the future might be bred so that we'll have 20 copies of P53, and we're like protected against cancer in the future.
Thinking about elephants not getting cancer made me wonder, so if you have an abnormal fear of mice, is that a good prognostic indicator?
So I think we try to keep up with what's going to come out. So I think you can make a strong prediction that there'll be data on bispecific antibodies, CAR Ts, and antibody-dependent, what are they called? ADCs, whatever that is in English. So using antibodies to deliver a warhead or a payload. And so I've been a bit down on ADCs because at some level I couldn't really see how they would work and do more than chemo. But there's one that comes from GlaxoSmithKline that delivers MMF to cells, and it seems to be having like really good response rates at the same sort of level as a CAR T in relapse refractory disease. GSK 964, yeah. But I think that's really quite exciting, and I think there'll be data on that presented there.
The other one that's very exciting, and it's been out there in social media all around, is this antibody called AMG 420. So AMG 420 is a product by Amgen, and what they do is one of those bispecifics. So you've heard about the CAR T cells, how they're engineered so they can latch onto the myeloma cells, and in doing so, it kills them. Another way, instead of engineering these T cells, is to have these antibodies that are kind of like matchmakers. So they bring together the myeloma cell and the T cell. Another way I explain, like a double-sided Velcro that puts them together, right? And then the T cell attacks the myeloma cells, and they're reporting on the phase 1 study, they're up to 800 micrograms, and they're having a large number of patients achieve a stringent complete response and MRD negativity at that response. Previously treated patients. This is the first presentation of this, so it's very early, but the results are quite spectacular.
Yeah, you may not appreciate it, but it's really unusual to have so many different drugs that are producing such remarkable responses in patients who have failed everything that we have now. So these drugs are being tried in patients who failed all of the drugs that we've basically talked about today. And then we're still seeing these complete responses that are durable using these drugs. And so I think Dr. Morgan alluded to this. When these new drugs finally get introduced into patients much earlier in the course, they'll be even better. So I think this year could perhaps be marked as one that really, last year there was two, the CAR T cells and this GSK, but this year there's several more. So it's really an astounding time in the treatment.
Yeah, so in that picture with the old man I showed you, Charles Darwin on one side, I tried to show that there are different ecosystems. And so early in the disease, low-risk disease, is dependent on the bone marrow to grow. In late-stage disease, the it will grow in the organs and it will grow in the blood as leukemia. So it tends to have a worse outcome, and it's one clinical group that we really can all agree is high risk. And so the current treatments are not perfect for that type of disease. We get people into a response, and I think that these new treatments are going to allow us to rescue people when they relapse from those responses. And I think that's why we're all so excited about them, because this is a group we can finally make significant improvements with.
Two good questions. The chemo brain, I think, don't make any important decisions when you're taking dexamethasone. I think Revlimid seems to be, no one's taking thalidomide anymore, but Revlimid and thalidomide seem to be the two drugs that patients seem to describe fogginess the most with me. And you have to balance your dose of those drugs versus the side effects, like with anything else. But your second question is very interesting. The reason why we recommend maintenance, I think, is we want to suppress those tumor cells because we think that the more that they are allowed to divide, the more they're allowed to grow, the more likely they're going to make a mistake. And so if we can suppress their growth and keep them down, we'll just prolong the length of time. The other thing that's an advantage to keeping the disease away longer is our treatments are improving so rapidly that if you can keep the disease away longer for an extra 6 months or a year, you may have better treatment options when the disease does actually come back, if it does, because it doesn't always. And so typically when we're giving maintenance, we often can't measure any effect of what we're doing. And so we don't recommend switching around to a lot of different things.
It's really interesting. So the Darwinian idea sort of works. You put in a selective pressure onto something, and so it's like treating bacteria or HIV. You're selecting for resistant clones. And so maybe if we knew enough about it, you could swap from one type of selective pressure to another type of selective pressure like we do with antibiotics. I'm not advocating doing that at this point in time. I think the data is remarkable with single agent lenalidomide. And for now, we should stick with what we know works, because Leaf worried for years about some data we produced that suggested if you had maintenance, your disease was worse when you relapsed. That doesn't seem to be the case. And so I think that's important. Maintenance with these drugs seems to be safe, well tolerated, and improves outcomes. So I reckon we'll all have three different, not answers, but different components to the answer. So I was going to address the issue with mutationally targeted treatment. So you find a mutation like RAS, BRAF, 8% of everybody. If you target that with a treatment targeted to that pathway, it kills cells. The issue is that most mutations aren't in 100% of cells. So if they're only in 50% of the tumor cells, only 50% of the tumor cells die. So what happens is you respond and then you relapse quickly. So at some level, mutationally targeted treatment just prunes the cancer tree. And what we need is to target the ones that cause the cancer, like the 414 and the 1114.
That's a great term. I'll use it, the pruning of the cancer tree, because that's exactly what happens. The immunity is very hard to measure because immunity means it's such a broad term. And so when someone tells me I'm taking this that it's going to enhance my immunity, it's like saying, I'm eating this food that's going to enhance my personality. what does that mean? It's like it's so broad. I mean, tequila notwithstanding, but the reality is we don't have very good ways to measure the immune system. So we measure it indirectly by the number of white cells, your lymphocytes, you know, how do you react to vaccination, for instance? But there's no good test to do that because it's such a broad thing. And then the drugs all play with immunity. Traditionally, we think that cancer drugs lower your immunity, and sometimes they do. Dexamethasone, for instance, lowers the immunity. It's very clear. The immunity is low after transplant, but because the neutrophils are low. But then there's drugs like the IMiDs that we think enhance immunity. So Ivan Borrello, that of course is very close to the crowd, has shown that if you get vaccinations while you're on Revlimid, your responses are better than if you don't. And there's some anecdotal experience which we have to be mindful about. If someone has had a solid organ transplant, like a kidney transplant or a liver transplant, and they get Revlimid, there's reports of hyperacute rejection of the organ. So the immune system really gets unleashed against that organ. So it's just a long way of saying we don't really completely understand the immune system, and even less so, we have not very good ability to manipulate it and measure it.
These guys always forget the basics. When you're diagnosed with multiple myeloma, one thing that's a characteristic is that you're making too much of one antibody, which that antibody doesn't do your immune system any good. But it means you're often not making enough of the other antibodies that your body needs to fight infections. And the drugs we give you to treat myeloma, they not only suppress the myeloma antibody-forming cells, they suppress your normal antibody-forming cells. So patients with myeloma have an immune deficiency of antibody production. And sometimes patients with myeloma get repeated life-threatening infections. And in those patients, we recommend giving them antibodies, gamma globulin. We give them infusions of gamma globulin once a week, and that can be used to prevent infections in those patients.